We now move to another chapter devoted to the pancreas. We had already talked about pancreatic disease in a lady who gets biliary pancreatitis, but the other type of patient who gets pancreatitis is the alcoholic, frequently male. So whereas in our previous chapter our patients were all fat females in their 40s with many children, now we're going to be talking about alcoholic males. Let's read vignette 61. A 33-year-old alcoholic man shows up in the ER with epigastric and mid-abdominal pain that began 12 hours ago, shortly after the ingestion of a large meal. The pain is constant and very severe and radiates straight through to the back. He vomited twice early on, and since then has continued to have retching. He has tenderness and some muscle guarding in the upper abdomen, is afebrile, has mild tachycardia. The serum amylase is 1200 and his hematocrit is 52. All right, let's analyze this vignette. The instant you read alcoholic with epigastric pain, you were already thinking pancreatitis. Then the description is very good for pancreatitis. The pain is epigastric, radiates straight through to the back, is constant pain with some vomiting. And then the diagnosis is confirmed because the serum amylase is elevated. Now you might have chosen to use lipase instead of amylase, same thing. But there is an extra bit of information. The vignette points out that his hematocrit is 52%. You know, the normal near sea level will be 45. You get that additional information because there are two types of pancreatitis. The common, relatively benign, self-limiting, you typically survive it, acute edematous pancreatitis in which the hematocrit is higher than normal. And the far more malignant, virulent, potentially lethal acute hemorrhagic pancreatitis in which the hematocrit is lower than normal. So when you read this vignette, you could make a pretty precise diagnosis. Not only that this is acute pancreatitis, but that it is acute edematous pancreatitis. So how do we treat that? We put the pancreas at rest. We actually have no medicines that make an angry pancreas better, or for that matter, operations that make an angry pancreas better. We put the pancreas at rest. NPO, NG suction, IV fluids, the patient will get better. Now let's read the next, vignette 62. A 56-year-old alcoholic man is admitted with a clinical picture of acute upper abdominal pain. The pain is constant, radiates straight through to the back. It's extremely severe. He has a serum amylase of 800 and a hematocrit of 40. Let me stop there. You know it's acute pancreatitis. You know it's hemorrhagic. You got a lower than normal hematocrit. Once we realize it is hemorrhagic, it may be useful to think, how bad is it? And there was a gentleman who took the trouble, his name was Ransom, to identify all the findings that give us prognostic evaluation of pancreatitis. I gave you all of them in this vignette, so let me read them. So at presentation, his hematocrit is 40%, his white count is 18,000, blood glucose 150, and serum calcium 6.5. All of those indicate this is bad pancreatitis. He's giving IV fluids, kept MPO with NG suction by the next morning. His hematocrit has dropped to 30. Serum calcium has remained below 7 despite calcium administration. His BUN has gone up, developed metabolic acidosis, and low arterial PO2. These are all the Ransom's criteria. This is a man who's going to die from his pancreatitis. Now, you don't need to be able, for purposes of the USMLE, to estimate mortality with a number, with a percentage. But if you read this vignette, you know this is very bad. So what do we do that might be different from the previous one, since we have no medicines to make an angry pancreas better anyway? Well, we do the same and a little more. Put the pancreas at rest, put the patient in the ICU. We expect every complication to occur. These people get respiratory failure, they get pleural effusions, they get all kinds of problems. And one of the problems they can get that may lead to their death. They may develop one or more pancreatic abscesses where the necrotic pancreas is. It's helpful if that is going to happen for us to recognize it right away. So part of the management of this patient includes daily CT scans. If we realize an abscess is developing, we drain it right away. Let me repeat some of these with a little bit of a decision tree. We're going to cut away from my face and go to words on the screen. So if we have severe epigastric pain in an alcoholic, we suspect pancreatitis. We confirm with amylase or lipase. If we are seeing this patient in the first 48 hours, we measure them in the serum. And if we see it after 48 hours, we measure them in the urine. Here is what an inflamed pancreas would look like on the CT scan. Now, once the pancreatitis has been diagnosed, we check the hematocrit. Remember, there are two kinds. If the hematocrit is increased, we have acute edematous pancreatitis. We put the pancreas at rest. But we have a patient with pancreatitis, if when we check the hematocrit, we realize that it has decreased, we have acute hemorrhagic pancreatitis. We need to put the pancreas at rest. We need to admit the patient to the ICU. We need to do daily CT scans. If we identify an abscess on the CT scan, we have to drain the pus. We treat the complications as they arise. These patients have many. And occasionally, I had not mentioned that with the vignettes, but occasionally late surgery is sometimes needed to scoop out the dead pancreatic tissue. Let's move on to vignettes again. A 57-year-old alcoholic man is being treated for acute hemorrhagic pancreatitis. He was in the ICU for a week, required chest tubes for pleural effusion, was on a respirator for several days, but eventually improved enough to be transferred to the floor. While he was in the ICU, he was getting CT scans every day. 2 weeks after the onset of the disease, he begins to spike fever and to demonstrate leukocytosis. This is a late developing pancreatic abscess. So you do another CT scan, you'll recognize the abscess is there, and you drain it. Now, vignettes 64 and 65 are two ways in which a disease of a pancreas may develop. A 49-year-old alcoholic man presents with ill-defined upper abdominal discomfort and early satiety. On physical examination, he has a large epigastric mass that is deep within the abdomen and actually hard to define. He was discharged from the hospital 5 weeks ago after successful treatment for acute pancreatitis. Now, before I tell you what this is, let's read the next vignette, because there are two ways you can get this disease. A 55-year-old woman presents with vague upper abdominal discomfort, early satiety, and a large but ill-defined epigastric mass. 5 weeks ago, she was involved in an automobile accident in which she hit the upper abdomen against the steering wheel. Both of these patients have developed a pancreatic pseudocyst. A pancreatic pseudocyst is a collection of pancreatic fluid where it doesn't belong, because it is leaking out of the pancreatic ducts. And the damage that allows the pancreatic fluid to leak out of the ducts is either the damage of acute pancreatitis or the damage of trauma to the upper abdomen. So that's why we have these two presentations. Both of them, the leading event happened about 5 weeks ago. 5 weeks ago, they had acute pancreatitis. 5 weeks ago, they had a car accident. And now they have this mass, ill-defined. It's a collection of pancreatic juice, typically in the lesser sac. You can diagnose it very quickly with a CT scan. It will give you a very good picture. A sonogram would give you a picture too, but the CT scan would give you a better picture. And then what we do next depends on how big is that pseudocyst and how long has it been there. And as a sort of a convenient little mnemonic, think of the number 6. If that pseudocyst is bigger than 6 cms or has been there longer than 6 weeks, you want to do something about it. If it is less than 6 cms or it has been there less than 6 weeks, you can watch it because it may go away. So what do we do if it is bigger than 6 or has been longer than 6 and we need to intervene? Well, there are 3 things we can do. We can surgically drain that pseudocyst into the GI tract, a cystogastrostomy or a cystojejunostomy. We can percutaneously, by radiological guidance, drain it to the outside, or the best, most sophisticated treatment at the present time, endoscopically drain it into the stomach. So the patient doesn't have to have an operation, which was the first choice, or end up with a tube draining pancreatic juice, which was the second choice, but gets an internal derivation done endoscopically. Let me review this again by means of a little decision tree. We're going to cut away from my face and look at words on the screen. So we have a patient who had acute pancreatitis or upper abdominal trauma a few weeks ago. That patient is now complaining of epigastric discomfort, early satiety, and there is a vague epigastric mass. This is a pancreatic pseudocyst. A sonogram will give you the diagnosis, or a CT scan will give you the diagnosis. For the management, we ask ourselves, how long has it been there? How big is it? Been there less than 6 weeks, smaller than 6 cm? Observation. It may go away. Been present for more than 6 weeks, is more than 6 cm, complications are likely, perforation, bleeding, infection. Better intervene. Either do percutaneous radiological drainage or surgical internal derivation, or endoscopic internal derivation. We have one more vignette for pancreatic disease, vignette 66. A disheveled, malnourished individual shows up in the ER requesting medication for pain. He smells of alcohol and complains bitterly of constant epigastric pain radiating straight through to the back that he says he's had for several years. He has diabetes, steatorrhea, and calcifications in the upper abdomen in a plain X-ray. This is a very good description of chronic pancreatitis. This is a very unfortunate man because this is a horrible disease. We unfortunately see these in alcoholics who've had pancreatitis many times. They keep drinking, it keeps getting worse, and eventually they develop this, which is called chronic pancreatitis. The pancreas doesn't work anymore. That's why they have diabetes, that's why they have steatorrhea. It's all calcified, but they don't care about that. What's killing them is the pain. Epigastric, straight through to the back, constant pain, day and night, very severe, 7 days out of a week, 52 weeks out of a year, constant pain. By the time we see patients like these, they typically have lost their family, their job, their home. They are homeless, they live under a bridge, and they continue to drink, now in desperation because of the pain. There isn't an awful lot we can do. We can give them pancreatic enzymes to take care of the steatorrhea. We can give them insulin to control the diabetes. But the pain is very hard to control. We sometimes do, as part of the workup, an ERCP to see if there is any type of obstruction that could be dealt with. Sometimes we identify what's called a chain of lakes, dilated duct with stones, and we can drain that somehow. But many of these patients never get satisfactory relief.